And most of this, I've put the references in. This is the end of the year. We start like January 1st week is when the ADA puts in their guidelines. First of the year as a supplement. It's a very comprehensive review. It's getting bigger and bigger with we recognizing all the different aspects of diabetes 1 and 2 and every other diabetes that we have, so I have no conflicts of interest. So always when I do a diabetes talk, I have to start with offering my salutations to Best in Banting. As you all know, McLeod and Banting here, they were the recipients of the Nobel Prize in 1925. So a very nice lecture in the website, I think the Nobel website, and 1921 is when they discovered the insulin. And it's a very interesting story by itself, how they treated this young child who then, was in DKA and regained the weight and everything. So we just do a case-based review. It's a regular patient. I think all of you all see this kind of patient every day in the clinics, and then review a little bit of the guidelines, what is different or what is new, which hasn't changed a lot in the last few years. And also, I think many of your patients now are Googling, looking into internet, they have friends, they have blog sites, they're into things, so they come in and ask about studies, trials, new options, especially technology. There's so much more. So I think it's a good idea to know a little bit about that. And there's a lot of fascinating new studies, and we are hoping to be a part of some of those studies also. So we'll start with this 50-year-old woman whom I've been seeing for the past couple of years, was referred by another patient who I had seen for thyroid disease. So she's your usual type 2 diabetic with a sort of obese A1C in the 8 to 9%, admits she's never had perfect control since diagnosis about a few years ago, and her blood pressure slightly on the higher side, and has some peripheral neuropathy on exam, central obesity, and a lot of fatigue. And I have done her labs. Her LDL is 102, and she's already been placed on a statin by her primary care. And there is trace microalbumin in her urine already. So she's already got a lot of these complications that you worry about with the neuropathy and some early nephropathy. And I know tomorrow there's going to be I'm looking forward to the DKD talk, the diabetic kidney disease talk tomorrow for the grand rounds. And she's been updated with the eye and foot care, and as far as we know, no retinopathy. So the story of her diabetes goes like this. She has tried metformin as it is recommended in the guidelines, starting with metformin early on at diagnosis, which was made as a routine diagnosis in a physician's clinic, and then later on sulfonylurea was added. And then later on, years before that, I think she was on TZD. But however, with the TZDs, she, I think, had some weight gain. And then, as you may not be aware, but rosiglitazone or Avandia was in press for concerns for increasing CVD risk. So there was FDA warning, and many patients who were on it wanted to stop it, although it helped a lot of them. It's the only insulin sensitizer available, that group of drugs, the TZDs. So she was on it, then stopped it, then went on a different TZD, with which, like I mentioned, had weight gain. And then she also had a fracture, and which is something we're concerned about with TZDs, is that there may be an higher risk of fracture, especially in postmenopausal women. And also, around the time she was on it, there was this concern about bladder cancer, which later we have 10-year data available that it's not as much of a risk as we thought it was. And so she stops all the oral agents, stays on metformin, and then starts off on basal insulin. And we all struggle with this cost of diabetes. There's a cartoon which floats around and says, do you want to pay for your diabetes meds, or do you want to be a millionaire? So that's how much the co-pays are with all the insulins. Insulins are so expensive now. There was a very nice editorial earlier this year or last year in New England Journal of Medicine about it. So she struggles to pay for her medications, just like many of our other patients. She works, she has insurance, but the co-pays are quite high for this. So then she her insulin dose requirement keeps going higher and higher, and she keeps gaining more weight. And then we start her on U500 regular insulin, which most of you all who have rotated with us or worked in the hospital service in the VA are familiar with this insulin. At a given time, at least 1 or 2 patients in medicine or in cardiology are on this insulin that we have. We almost have about 40 to 50 patients at the VA with this. It's one of the most potent available insulins, and it's U500. There's very nice review about it in endocrine practice. I can provide the reference later. And so she gets on it. Her sugars are a little bit better controlled. However, she gains a lot more weight. So, and her transaminases start going up, as we all know, fatty liver, hepatic steatosis, common problem with type 2 diabetes. And she also gains more weight, so she's diagnosed with sleep apnea at this time. Her sugars are not completely under control, so she wants to know what else should we do. So that's where we kind of stop and perhaps go into the different options that this patient and several patients like this have available. And of course, one thing to kind of plug in, I just have one slide on it. If we have time, we'll go over it, is that in 2012, New England Journal of Medicine, this publication came about curing diabetes with bariatric surgery. So there's been a lot of press about it. The trial that mostly looked at it, the longitudinal trial, is called Stampede. It's out of a Cleveland clinic, and it's a very nicely done study looking at sleeve gastrectomy and diabetes. And if we have time, we'll go over it. Otherwise, it's just an option available to many patients. But of course, there's criteria for going to have surgery, and you have to be over a BMI of 40. And she was, I believe, 35. So, and plus, she didn't want surgery. Many patients are afraid of surgery. I just summarized the references, but of course, it's available to you later on. So type 2 diabetes, the mechanism is both a combination of central pancreatic decreased insulin secretion over time with increased glucagon, which causes gluconeogenesis. Apart from that, also excess hepatic glucose production. So normally when you go to bed, sleep for 8 to 12 hours, wake up, didn't eat anything, you expect your sugar to be low. But in diabetes, progressively in type 2 diabetes, they wake up with very high fasting numbers. They could be fasting for 10 to 12 hours, but still end up with very high blood sugars. And this usually happens because there's hepatic glucose production, which is independent of plasma glucose levels. And also there is decreased peripheral glucose uptake, as you can see here, with exercise in the muscle and in the adipose tissue. So it's a combination of progressively decreasing insulin secretion, which is not the first factor. Actually, it's mostly these two. And then later on, as type 2 diabetes progresses, patients, as you would notice, become insulin dependent because the endogenous insulin production does go down over time. So that kind of helps us look at, sorry, I forgot the rest of it. And there's also some talk about neurogut control of this whole thing, hypothalamus, and how it controls this. And there is at least one drug available now which kind of addresses that. And of course the incretins, which is the other group of drugs we're going to talk about, which is a gut hormone. And I don't know if I have the renal thing in here, but this was a little bit older slide, as you can see. But now we have the kidney also, because that is the third drug we're going to talk about. So diagnosis of type 2 diabetes, it's important to know because patients get so upset when you give them the diagnosis and they argue, they go in and they say, well, this is the number and this is what it says. So because it's a liability once you get the diagnosis for insurance companies, for work and everything. So 6.5% A1C. Usually it's recommended that you repeat it within a few weeks because you can't go by one A1C. Or the gold standard 75-gram oral glucose tolerance test, which we seldom do anymore for this diagnosis. Most of these patients are diagnosed based on their fasting sugars, which is 126 milligrams for fasting over 8 hours. That's more important. It's not the overnight snacking till 4 a.m., then sleeping and coming to a lab at 8 a.m. or a 2-hour postprandial over 200 with the glucose tolerance test, or any random plasma glucose of 200 gives you the diagnosis, along with the hyperglycemic crisis, presenting with some infection. You guys see it in the hospital service all the time. First diagnosis, we're never aware of it. So that is the criteria, and it's important to know that. Why are we so worried about diabetes as such? I don't need to tell the group, you guys talk about this every day, but this study looking at the DCCT, which is one of the very well done, like a seminal study in the 90s to 2000, very, very well done control cohort group studied with very tight control of blood sugars in the study group, which is the type 1 diabetics. And those days we didn't even have Lantus or anything available. It was with NPH and regular insulin. And the other group was a conventional twice-a-day insulin. The study group had multiple injections 5 times a day. So, and progression of complications in these patients, looking at, what retinopathy with A1Cs, the progression with A1C with retinopathy, progression of albuminuria, neuropathy, and also microalbuminuria. So the higher the A1C, worse the complications. And these are the kind of the major studies that we always kind of refer back to again and again when we talk about why is good control so important in these patients. So UKPDS was an early type 2 study done at United Kingdom looking at 3,000 type 2 diabetics and doing a longitudinal study. They were followed longitudinally, and there was good control, and this wasn't even like 7% or below. It was a difference of between maybe 8 to 9% versus 12 or 13, just not that tightly controlled, but it showed remarkable improvement with microvascular disease, and some difference with, this is initial trial, and this was long-term follow-up. Because all these patients were brought back again later, even after they got out of the study. And the blue here is the second, like after the study was completed, about few years later, patients were brought back. And at that time, they were not in the intensive group, but still they had so much benefit, both in DCCT, which is diabetes control and complications trial, and UKPDS. Microvascular, big difference. So neuropathy, nephropathy, retinopathy. Some of them was actually as much as 78% reduction in retinopathy. And then macrovascular disease, some difference, some benefit. It depended on if you control their blood pressure, lipids, and everything. But definitely there was definitely a difference. And also a difference in mortality in terms of in UKPDS, which is type 2 diabetes. And ACCORD, again, microvascular disease improvement. This red arrow here is interesting. A small subgroup of ACCORD did have a higher mortality with tight control, but those patients were older patients who had been diabetic for much, much longer and were at a higher risk. And more recently, we had a publication related to that, which I won't have time to talk about today, but it's a very interesting observation that was made in this subgroup of patients. And the same goes with the VA diabetes trial and ADVANCE. And most of this showed a very powerful microvascular control. So that is important. And this is something I like to show every time I do a diabetes talk. And this is why we tell patients the first few years are the most important when you're diagnosed. Because when you have intensive treatment, even when they get off the treatment, the body or the metabolic memory stays. It's called the legacy effect or the gift that gives. It goes on for, the effect of the control, early control lasts for much longer. So I tell my young type 1s, we have to work on this early on and get it together. We don't want to wait. So the first most important thing we tell patients is lifestyle. So which I know right now we have, which we didn't have before, we had to refer outside. We have our own certified diabetes educator. You can place a consult in the ULP educator. And we have a dietitian now. So we have 2 people to work with. So the first and most important thing we talk about, and Passport also has their own set of educators, is lifestyle. So, and diabetes education. And that is the most kind of the hallmark of the whole thing. I always tell patients you have to go there at least once. It's as important as seeing the physician. So, and of course, most of them haven't had a diabetes class. If you look at the data at how many people have actually attended a ADA-approved diabetes education class, it's not too many patients. They feel like they can come and see the physician, but they would never want to go see the educator or spend that time and energy that's involved. But insurance companies do pay for this, and Medicare does pay for it. So the main things in the standard of medical care right now is more focused on gestational diabetes or even pre-gestation, even before the woman gets pregnant. There's a lot of interest in that. And a lot more elderly, as our geriatric population gets larger and larger and we treat them for other diseases and they live longer, diabetes becomes, if you look at the prevalence of diabetes over age, your highest prevalence is older patients over the age of 65 or 70. So that is a bigger group of patients that we are all going to see on a regular basis. And there are certain things that are a little bit different about these patients. And just yesterday, I think there was a publication through CDC looking at the current diabetes rates. And for the first time in, I think, several decades or maybe several years, the diabetes rate has stabilized in the United States in terms of new diagnosis. However, it was interesting. Many patients said many of them didn't know that they had diabetes when they were told that they had it. So they were kind of had it for a while before they found out they had it. And also the ethnic differences I wanted to highlight, because now that we have the global healthcare and we are seeing a lot more refugee patients, in this CDC study published yesterday, they did talk about a higher incidence in Asian Americans living in the United States because of the body mass index. We kind of miss the diagnosis because we wait till they gain the weight, and many of them don't gain weight and have diabetes much earlier. So that is an important group to think about, is the ethnic group. And of course, other issues such as diabetes and cancer and diabetes and bone disease are also important. So one of the things that ADA always, the statement they put out is providing care that's respectful and responsive to individual patient preferences, needs, and values, and ensuring that patient value guidelines guide all clinical decisions, which means the patient is the driver of the whole treatment. Because it's been interesting how many times you write the prescription, you go over everything, they come back a month or two later, they never even went to purchase it because the copay was too high. But they kind of felt reluctant to call and tell you that they couldn't afford it, came back a month later with the same numbers. So it's so important to make sure the patient is involved in the decision, and all the treatment is patient-centered treatment. That is like kind of the party line for ADA and EASD now. So, and of course, the rest of the care, which you guys are awesome about, which is looking at medication management. We have our own pharmacist faculty here, foot care, eye clinic, and all the other issues, including GI and behavioral psychology, which we don't have available right now, but we are working towards that from some of our high-risk patients. I think it's a very important aspect, having a behavioral psychologist who's very familiar with diabetes to work with them. And also wellness program, which is available to employees, but it'll be nice to have it for the patients. And we won't go into the lipid guidelines and all that. I think you've had several talks about that. Vaccination, of course, but everything else I think has been covered in the past, so I won't go into it. So the recommendation by the ADA, and which we do. Now, this is slightly older. This looks a little bit different in the recent one because here we just have metformin, but in the newer ones, many other drugs are in there, just such as DPP-4 inhibitors in the first year when the patient is first diagnosed, and the A1C is probably 7 or less than 7 or less than 7.5. Usually we always said metformin, but now we have other options available, glipizide. You can even use Januvia as your monotherapy. Even GLP-1 has been approved for monotherapy. Before it had to be add-on therapy at the second level, so that has changed. So I think I went too fast. So this is the second year where you've tried it for 3 months with monotherapy, and the A1C is still more than 7.5 up to 9%. then you add on other drugs, which could be sulfonylureas, TZDs. We still feel like there's a role for these drugs in certain patients. That is Actos or Avandia is not used as much, but at least pioglitazone, we still have some patients. And a DPP4, which I'll be talking about briefly, and GLP-1 agonists. And I don't see the SGLT2, but that's also here, and we'll talk a little bit about the SGLT2. And then if your A1C still continues to be high, you tried this for 3 months along with lifestyle changes and everything, then you can add on a third drug, which could be insulin and or any of the others. The most important thing to remember is you cannot use a DPP4 together with a GLP-1, and I'll talk about it a little bit. So those are your options available. And of course, once the A1C is over 10%, mostly you have to go with insulin. There's not too many other options available, along with the lifestyle changes. So then it becomes more complicated. So what I mentioned about elderly patients and other comorbidities, and knowing that these patients, it has to be patient-centered. So if somebody has very low risk for hypoglycemia, like younger patients, or have very good hypoglycemic awareness, and if they're early diagnosis of diabetes, it's not like they've had it for 25 years or so, and if the life expectancy is very good, and they don't have too many other comorbidities like metastatic malignant melanoma or something like that, then it's okay to go for very stringent control, tight control, which is a fasting less than 130, 80 to 130, and a postprandial 180 to 200, and an A1C goal of less than 7% or 6.5%. However, you have an 85 or 88-year-old patient who's a high fall risk, has dementia, has had previous metastatic cancers, or has severe hypoglycemic unawareness. They can be at 30 and not know, and the next thing they know, they're seizing and probably broke a hip from falling. So those are high-risk patients. You don't use the same A1C cutoff for these patients. You have to scale back and say, maybe even them, we be more conservative and use a 8% or 8.5 or a 9% A1C, because their life expectancy is not as long, and plus causing hypoglycemia will cause more damage than good for these patients. So that's the most important thing to remember, is to set goals. So next we'll go to one of the important class of drugs that is available, and that, like I used to tell when this was first in the market, but now it's been about almost 7 years. We call it the story of the beast. So this is the Gila monster, whom many of you all, if you had been in my talk before, have seen. It's one of the lizards in the Mexican deserts by the Gila, I think the Gila River. And several years ago, this lizard is unique because it can eat a prey and be good for several months. It feels full because it makes, in its salivary gland, makes this hormone called exendin, which keeps its satiety up, so it doesn't feel hungry for a while. So that was this is the beast that was responsible for this medication in a way. So the drug we're going to talk about, which you all know, familiar with, is a group of incretins called GLP-1, which is glucagon-like peptide 1. And it is a gut hormone. It's made in the L cells in the small intestine. It's made from glucagon, actually, and then cleaved with proglucagon, and then comes up as GLP-1. And it's a very interesting mechanism, how it works and causes the effects that it does. So the effect is called incretin effect. So if you did an IV glucose tolerance test, like right here, this is the intravenous, and this is your oral glucose. You give insulin intrajejunally. And look at the plasma insulin levels. The oral glucose tolerance test, when you took glucose orally, the insulin levels were much higher at 60 to 90 minutes compared to the intravenous. That difference in the insulin between the IV and the oral is called the incretin effect. And that effect is by the GLP-1. So any times you ingest food, then you develop this incretin effect if you're healthy and normal. This is healthy subjects. And of course, in diabetics, the GLP-1 effect is lost over time. And that was the whole idea of replacing your glucagon-like peptide effect or preventing the breakdown of endogenous glucagon, that GLP-1 that is made by the body. So those are the two kind of ideas that cause the development of this drug, which is the glucagon-like peptide. This is the one. I think it's 17 to 37. That is the amino acids. And then also, and you all are familiar with the Victoza or liraglutide. And exenatide was the first one which became available about 8-9 years ago. I was a fellow at the time, I think. Byetta was the name at the time. And since then, we have a lot more available, and we'll look at some of the names. And also, these are the DPP-4. Vildagliptin is not available here. It's available in Europe and Asia. The FDA didn't approve it here, but we do have sitagliptin and, of course, several other gliptins that Passport and Medicaid pays for. So how does the GLP-1 work? So for that, we have to go a little bit into how insulin is released. And it's a very beautiful mechanism. And, every time I look at it, it's never boring to me. So GLP-1 interacts with the beta cells by the cognate receptor called GLP-1 receptor. So, but before that, we would quickly go into how glucose is taken up into the islet cells through the GLUT2 transport mechanism. This is the GLUT2 mechanism. Glucose is taken in and it's acted upon by glucokinase, and it's made into glucose 6-phosphate. That again changes the ATP ratio. And when you change the ATP ratio, that changes the mechanism and closes these potassium channels. You close the potassium channels, you open the calcium channels. And the calcium release then causes insulin release. And that's how this whole very tightly knit mechanism works within the islet cells, beta cells. And GLP-1 actually has a receptor here and in the beta cell that also stimulates the release of insulin in the similar mechanism. And so that is kind of going over the molecular mechanism of it. And what does it do clinically? So it does what we call as glucose-dependent insulin secretion. It doesn't increase your insulin secretion if your glucose is low. And that is very important to know. That is important to know because this drug does not cause hypoglycemia when used alone. And you all probably know now that it's been approved for a weight loss drug. It's called Saxenda in much higher doses in obese patients. So these patients do not have to be diabetic. So when you use a GLP-1 by itself, you're not going to cause hypoglycemia unless you add it as an add-on therapy to other drugs. So that's something to remember. It's a glucose-mediated mechanism of insulin release and suppression of glucagon. So fasting insulin concentration can go up, first phase, second phase insulin, and also postprandial insulin secretion. And the glucagon secretion is lowered, thereby there's no, which is another mechanism that is faulty in type 2 diabetics is they make inappropriate glucagon secretion causing hyperglycemia. And also, the other thing that GLP-1 does is it slows gastric emptying, just like the Gila monster, so it feels full for a long time. And so thereby, there's decreased food intake. So most of your patients are going to feel a little nauseated in the beginning, so we want them and tell them take it a little bit further away from the food first and then bring it closer. That is if they're using the exenatide. Of course, if they're using liraglutide, it's once a day, so it doesn't make a big difference. We talked about what are the defects in type 2 and how GLP-1 acts on those. And the next one in the same group, incretins, is the DPP-4, which is all the pills that are available. There's sitagliptin, linagliptin, saxagliptin, which is on Glyza. And the way it works is it inhibits the breakdown of GLP-1 and GIP. So the DPP-4 inhibition, so that increases the endogenous GLP-1. So that's the way it works. We won't go into much detail into the other mechanisms, but there are several drugs available. I'll first talk about the drugs, then go into the concerns of the side effects. So the first one in the market was exenatide, which is Byetta. It's still available. It's twice a day. But then within the last 3 years, the exenatide was made into a once-a-week slow-release drug. It's called Bydureon, which many of the insurances cover. It's 2 milligrams. So we use that now. It's once a week, and the effect is actually much better, and patients tolerate it better. Liraglutide is the other drug which came into the market about 6 years ago. Those of you all who worked with me at the VA know we had about 25 patients in that study. It's called the LEADER study. And we just closed the study just this month. It's looking at the CV outcomes in these patients. It's called Victoza. And more recently, just this summer, liraglutide at a much higher dose, 3 milligrams, became approved for weight loss in obese patients. It's one of the obesity options available, and it's available at 3 milligrams actually. It only costs $1,000 per month. So, albiglutide is again a weekly available drug, and dulaglutide is also weekly. So we have 3 weekly GLP-1 options available right now. I think this is Trulicity, and this is called Tanzium. So those are the trade names. But so those are your GLP-1s. The DPP-4 inhibitors, which you guys use more often because I know Passport covers saxagliptin. The T is missing here. And then there is sitagliptin, there is Januvia, and linagliptin, which is Trajenda, and alogliptin also. Among these, they have combination drugs too with metformin, so it's easier to use because most of the patients who have A1C less than 8%, usually we do metformin with Januvia or metformin with Onglyza, and they usually tolerate it pretty good. It's weight neutral, and actually some of them actually even lose weight. So what are the concerns of the side effects? Because every time you start these new drugs, you always worry about what all do I need to know. So interestingly, when the GLP-1s came into the market, there was all these islet biology, islet scientists were very worried about stimulating insulin release from beta cells over time. Would it be a concern for pancreatic neoplasia, PNETs, or pancreatic neuroendocrine cancers, also pancreatitis. So this 5-year data that is going to be published from this LEADER study is going to help us look into all that. But at least the interim data showed that pancreatitis was no higher than the rest of the other patients. So unless they are at risk for pancreatitis, like for instance, you had a patient who had very high triglycerides, previous history of pancreatitis, heavy alcohol use, has had gallstones or issues with gallstones, then that would not be a patient I would start this drug on. I would probably wait a little bit and bring their triglycerides down. And the other group of patients whom you do not want this drug to be used, which is MEN, medullary thyroid cancer patients, and also MEN 1 patient, multiple endocrine neoplasia 2 patients, because in the animal studies, there was some concern that the thyroids of the rats had C-cell hyperplasia, which is the calcitonin or the medullary thyroid cancer producing cells. So there was a little bit concern about that. So if somebody has MTC, which is quite rare, or MEN in the family, I would not use this drug. And other than that, there's no major issues. Of course, somebody has gastroparesis as a complication of their diabetes, then you do not want to use this drug because this already slows your gastric emptying. If somebody has that, then it's going to be a disaster giving them a GLP-1. They're going to end up in the hospital. So that is about the GLP-1 drugs. Now, in terms of the DPP-4, the pills that we use, there was some concern in 2013 at the ADA when the study with 16,000 patients were looked at with hospitalizations. There was some concern that CHF exacerbation was more with saxagliptin use. However, when sitagliptin, further trials, which is TCOS and Elixir, looking at sitagliptin and linagliptin, when they came up with their longitudinal studies, they didn't show the same effect. So it doesn't seem to be a class effect. So if somebody has uncompensated heart failure, history of heart failure with frequent admissions, you do not want to use the incretins, especially the DPP-4 agents. And naturally, these patients go in the hospital often. They're sick a lot. So insulin may be safer in many of them than other drugs. Because anytime they go in the hospital, anyway, you're going to stop all the oral agents. So there's some very good reviews looking at it in New England Journal 2014 about the pancreatic safety of this drug. And it's important to discuss this with the patients because you don't want them finding it from someone else. So that is about the incretins. And then we'll talk about SGL. Tyler, how much time do we have? 5 to 10? Okay, I'll hurry up. Okay, the next group of drugs, which there's been a lot of press about, so I have to talk about these drugs. And that is so we talked about the gut control of diabetes through the gut hormones, and this will be through the kidney. And these are the sodium glucose co-transporters. And so it's, let me see. I think I kind of flip-flop these slides. Maybe. Let me look. Or maybe not. So it's a transporter. The SGLT2 is a group of transporters located in the kidney, mostly in the proximal PCT, proximal convoluted tubule. And there's SGLT1 and SGLT2. So interestingly, there was this familial syndrome of patients who had mutations to SGLT2, and those patients, those families, they would have, if you did the urine dipstick, it would be 400, 500, 800. However, they never developed diabetes. So it was renal glycosuria. It was a way of getting rid of your glucose without developing diabetes. And that was kind of the idea behind this whole SGLT2 inhibitors, because they reduce blood glucose levels by increasing your renal excretion of glucose. It's a selective inhibition of it. So also there is a kind of a downstream outcome, which is these patients lose a lot of weight also over time. So, and I won't go too much into the mechanism, but so where it is the glucose filtration, and this is the SGLT2 in the PCT, and this is where the glucose reabsorption occurs there. Almost 90% of the glucose is reabsorbed here and 10% here. And these group of drugs work in this area and decrease the glucose reabsorption and increase the glucose excretion. So I think I have one study to look at the A1C, but the group, there are several of them available now. Canagliflozin, DAPA. Canagliflozin is Invokana. It was the first one to come into the market a year and a half ago. Dapagliflozin, empagliflozin, which is Jardiance, and this is Farxiga. There's also more drugs in phase 3 trials. Some of them I can't pronounce, so I'm not going to talk about them. But the main concern earlier, when I made this slide first months ago, the main concern was increased GU infections, which is kind of natural if you think about it. These are patients who are excreting a lot of glucose, and they're diabetics. They're more prone to infections. So there's been some concerns about pyelonephritis, UTIs, and in women, refractory yeast infections, which you have to treat again and again. And actually, this patient that we just spoke about, I did try her on SGLT2, and she had a really bad UTI where she needed to be treated twice, and her calcium started going up. So the next thing I said, okay, we're going to stop it. So we kind of discontinued the SGLT2 in her case. Although some patients tolerate it really well. The most important thing to tell these patients is drink a lot of water, hydrate yourself. Because when you're excreting glucose, you're excreting water. So many of them have polyuria, and so they have to keep up with the hydration. And the reason I talk about that is we did have a study published from I don't know if Rachel was there when we had that patient in the hospital. This was a patient, this is one of the 20 cases reported to FDA, and this case was seen by us as an inpatient consult at Jewish. And this was from an outside provider. The drug had just come into the market. The patient was started on it. presented with DKA, severe hypercalcemia up to 14 or 15 milligrams, and also severe hypernatremia, and was quite ill. So this is presumably type 2 patient. So since then, the FDA has placed a black box warning and said these patients need to be cautioned about DKA. And with the DKA, you don't expect DKA in type 2 patients, usually, most of the time. So these patients, the unique mechanism is that the glucose doesn't have to be high. They can have a blood sugar of 250, 300 and still go into DKA. So it's extremely important to reassess your patient, make sure it's not a wrongly labeled patient as type 2, somebody who was actually maybe a type 1, a late onset autoimmune diabetic, a LADA patient who was wrongly labeled as type 2. So it's very important to tell them about hydration, genitourinary infections, and also about the DKA risk. And in fact, some of them I do give them ketone strips. If they feel sick, dip the urine and make sure. So that is the concern. And then more recently, there was some concern that one of them, at least in, I think, canagliflozin or Invokana, there was a higher risk of fractures. Now, that we are not very sure about, and that could go along with the sodium glucose co-transporter, lower sodium hyponatremia, and all those things. So we're not sure, but that's something important to remember in these patients. There are a couple more drugs. One is anybody familiar with bromocriptine being used as type 2 diabetic agent? Okay, so I have to tell you about it then. So we look at the hepatic insulin sensitizers. We looked at the gut as a mode of diabetes treatment, and we looked at the kidney as another treatment. Well, this is a central mechanism. It's a neurogut pathway. This drug works by regulating the hypothalamic regulation of appetite, and also works by hepatic insulin resistance improvement. And it's cycloset. It hasn't, personally, I haven't used it a whole lot, but it's like an add-on therapy, another option available to patients. It's immediate release bromocriptine mesylate, and it's available in different doses, and it's given first thing in the morning. It is, it's not a big difference. It's 0.6 to 0.9 A1C reduction when it's added. Cycloset is the trade name, when it's added to another oral agent such as metformin. So that's something you ought to know about. I won't go into much into the details. And are you all familiar with colicevalum? It's also another option available as for A1C reduction up to 1% actually. And it's a bile acid sequestrant. It's been available in the market for a while. And it's looked at it also causes LDL reduction. So actually some of our transplant patients are on this drug. So you may have seen that on their list. But it's multiple pills. It's like 3 tablets twice a day or 6 tablets once a day. So many patients are not very happy with that. So I won't go much into the details of the other, because we don't have much time. I was going to talk about the gut microbiomes and everything, but I think that's beyond our scope today. But so something else to remember is gastric bypass or weight loss surgery as an option to patients if the BMI is over 40, or if they're over 35 but they have other comorbid conditions such as severe knee arthritis, they can't mobilize themselves or anything. That is an option available that the patient has to be aware of. So let's see. A quick couple of things about type 1, because I know you guys are seeing a lot more type 1s now in the clinic. So the 2 newer insulins available, or 3 newer insulins available within the last year, U300, I don't know how many of you all are familiar with it. It's called Toujeo. It is Lantus, but it's concentrated 3 times. So it comes in a pen form. There's been some studies looking at it. You can, and it's shown some improvement with control compared to regular Lantus. So Lantus to Lantus. So it's called U300. It is available. Very expensive, but available. So the other option for prandial insulin, you all are familiar with the Lispro and Lispro and Novolog, which is Aspart, and Pedra, which is Glulysin. But this is the fourth option available. It's called Alfreza. It's an inhaled insulin. It's just got into the market this summer. So we don't have a whole lot of experience, but it's being used before meals. So it saves patients from having painful injections. So some patients just love that. But these patients require that you do PFTs or at least do a FEV1 every 6 months. So you need to, have PFTs available to you, or it could be done at the office. But it's very important they monitor. And there are several patients who won't be candidates, especially in Kentucky with COPD, asthma, and all that. So almost feel like, and children can't use it. So that kind of, excludes that. So the third new insulin in the market now is called Degludec. Those of you all in the VA may be familiar. We have a 5-year ongoing study called DEVOTE, DEVOTE, and it is on this drug. It's now available. It was in Europe for the last 2 years, but it's available in US now. It's called Degludec. It's a long-acting insulin. It seems to be pretty good in terms of as a basal option. It's a third or fourth basal option that you have available. Let's see, I just wanted to quickly go over the technology real quick because that is like a real big thing now, especially this week in the endocrine news. They talked about iRobots, artificial intelligence with helping with sugar control. And of course, you all are familiar with the Fitbits and the Apple Watches in terms of tracking patients' calories. So this is a smart lens so the life science group at Google is now partnered with Sanofi Aventis and with Dexcom, which is CGM, or continuous glucose monitoring system, and they've come up with a lot of new technology. So this is supposed to be glucose monitor, especially with the patients complaining so much about being like a pincushion. We're having them checked so often. So this is kind of a neat new thing. It's not in the market yet, but we're hoping it'll be there soon. And also the other big thing is the artificial pancreas. And there's a lot of excitement. There's in preliminary studies, at least 2 different kinds of artificial pancreas. In one, it's 2 different pumps that the patient wears, which communicate with each other. One has the insulin, the other one has glucagon. These are mostly type 1 patients because what limits your glycemic control in type 1 is the severe hypoglycemia because they don't have islets, they don't have alpha cells, glucagon, or beta cells. So this kind of communicates so it can provide both insulin and glucagon. The other artificial pancreas system is an external device which kind of looks at the incident blood sugar and controls the insulin rather than the patient deciding what to do. So those are neat new mechanisms. There's a lot of excitement about all these new products. So those are the ones available now. So I'll stop there and take questions. Just wanted to leave with this quote from the scholar Maimonides, who's also a physician. He was the author for Torah, the Jewish text, and treat the patient and not the disease. And, cost is a big factor and how much they can do. So set goals first and then talk to them and involve as many multidisciplinary educators, pharmacists, and that is always helpful for the patient and for you. So thank you very much.